In terms of singing this, there's just too many slides. I was just looking at it. I'd have to wrap it. I don't think you want to hear that. So I'm going to talk through this instead. Thanks everyone for hanging through all these great talks. I'm going to talk about something really gets a sort of bee at my donkey over the last 20 years, which is the control of extracellular volume in dialysis. Okay, so an overview of what I'm going to talk about. I'm going to talk about the expansion of extracellular volume in CKD, the consequences, the barriers to treating it, what trials have been done, attempts to restore it in dialysis, and future directions. All right, well, we're here in Seattle, so we know that this is sort of the birthplace of chronic dialysis treatments. And now here, 60 years later, there's about 430,000 patients receiving in-center hemo in the United States, and it's not going that great. So the treatment is beset with problems, frequent hospitalizations, debilitating symptoms, and premature death. At present, the 5-year survival for patients initiating in-center hemodialysis is still only 42%. There have been advances. We've got catheters made out of Teflon. We have fistula, biocompatible membranes, and my favorite advance in end-stage renal disease, the touchscreen, which now allows us to sort of teach the other people how, at least in the case of CRT, how things are working. But we have a lot of things still to come, including the removal of protein-bound toxins that we don't take out with dialysis, synthesizing the hormones that the kidneys make, having truly biocompatible membranes. We're told these are biocompatible, but of course, people receiving dialysis therapies, when their blood runs through the tubing and the semi-biocompatible dialyzer, they have chronic inflammation, and then minute-to-minute regulation of volume. These are things the kidneys do that the kidney machine does not. I always want to remind people that there is a large group of toxins that are considered to be uremic toxins by the European Toxin Working Group that are tightly bound to albumin, more than 90%, and these are not removed with dialysis. So this is just another way that the kidney machine is not yet a kidney. It leaves patients with end-stage disease full of the toxins that are bound to albumin and don't come out. And this remains a problem. And you've seen evidence in your everyday practice that a dialysis machine is not an actual kidney. This is older data, but has held up over the years, comparing people on the transplant wait list to those on dialysis to get an idea of how good the artificial kidney is at present. And you can see that the mortality rates in all the groups are about 50% lower in people who receive the transplant than those who remain on the wait list getting the artificial kidney 1.0. Okay, and so with that context of our current artificial kidney not being a real kidney, one of the limitations of the artificial kidney at present, at least in the setting of using prevailing intermittent thrice weekly dialysis treatments, is the inability to control extracellular volume. So this all starts way back before end-stage kidney disease. It starts with CKD. When you lose functioning nephrons, you lose the ability to excrete sodium, and there's a steady buildup of sodium and water in the extracellular space. I like this study because this group actually attempted to quantify how much extracellular volume people with chronic kidney disease gain. This is a cohort of people who had a GFR of about 44, so stage 3-4 CKD. Half of them were already on a loop diuretic, and they just went ahead and let them do that. And they measured their extracellular volume every year. I'll talk in a second about how they did that. And they calculated the annualized increase of extracellular volume in CKD to be 136 milliliters per year. A little lower than I might have expected, but still a steady gain. People might ask, well, I didn't think it was possible to measure extracellular volume. It is. It turns out if you give a tracer that's distributed throughout the extracellular space, and a great example of one is the ones we use for measuring GFR, like chromium EDTA or iohexol. If you give an injection of a set amount of that, and then you collect urine over the next several, say 2 hours, and figure out how much comes out in the urine, well, now you know the total amount that's in the body. If you draw a blood sample after that time, allowing for this equilibration, you can calculate the ECV as the amount of of the tracer that you put in the body divided by its plasma concentration. and that will give you the extracellular volume. So if patients with CKD are gaining extracellular volume every year progressively, and CKD is a long, protracted disease, we would expect that by the time ESKD is reached, people would have a lot of extracellular volume at that time from all this CKD. And in fact, that seems to be the case. This is a cohort study of incident hemodialysis patients. So they had started within the last 3 months. The study did not give exact data about within the last 3 months what was the distribution of time, but they were considered incident patients for that reason. They were from countries all over the world except from here. And they measured or estimated fluid overloaded using bioimpedance. And I'll talk more about that because that technology has some limitations. You can see, given those limitations, still, most patients who reach end-stage kidney disease have volume overload. The average was 2.7 liters. Many of them had much more than 2.7 liters of extracellular volume at the time ESKD was reached. And this is just further evidence of the overload. These are in patients, the studies in patients who were well dialyzed and either receiving hemodialysis or peritoneal dialysis. And they did this procedure called sodium MRI, which is a way of scanning for sodium in tissue. And this is actually a picture of the images in a single person, in 3 single people. You're looking at the calf muscle here, and they're looking for sodium in the muscle and in the skin. And you can see that in this case, representative patient with hemodialysis and peritoneal dialysis, there's considerable sodium, both in the calf muscle and in the skin compared with control. And this is just quantifying that. The MHD is in the middle. That's the maintenance hemodialysis patients, and then PD on the right. And there is an increase in sodium in the muscle and in the skin. Sort of supporting the idea that when you get to end-stage kidney disease, there is sodium everywhere. The extracellular space is expanded. The sodium is going everywhere. They are full of excess salt and water. I think this is the appropriate picture in terms of thinking about a person who reaches end-stage kidney disease. This is where we're at when they get there. And as you'll hear as I go along, I think the most important first step when this happens to your room is to dry it out. I think it's hard to do anything from here when your room remains flooded. So in terms of consequences of having this extracellular volume excess, certainly there have been studies showing associations of ECV excess in dialysis with mortality. But I think there's more to talk about. The classic triad that you get from extracellular volume excess is this syndrome of first resistant hypertension, where none of the blood pressure meds are working and they remain hypertensive, leading to cardiac hypertrophy, leading to pulmonary congestion. And one of the big consequences of that is this vulnerability to hospitalization for pulmonary edema, a little cold, and all that extracellular fluid rushes into the lungs, and now you're in the hospital for flash pulmonary edema or supposed heart failure. I was surprised by just how much this happened. I knew it happened a lot. This was a Medicare sample study of 176,000 HD patients, followed over a median of 2.5 years of follow-up. There were 35,000 hospitalizations for volume overload over this period of time, with an estimated cost of $266 million. So not just the cost, but from a patient standpoint, being admitted to the hospital repeatedly for volume overload, catching another infection while you're in the hospital, this is a bad consequence of having ECV excess. Another one is immobility. We know that there's a lot of immobility in end-stage kidney disease. And just if you start from the fact that you're having ECV excess and your feet look like this, you can't put on those fancy new sneakers and you can't get out and start moving around. It's a part of a vicious cycle that keeps people immobile. And then symptoms. And this is data from about 500 patients who were receiving in-center hemodialysis who completed what's called the Kansas City Cardiomyopathy Questionnaire, modified for kidney disease. And if you saw this questionnaire, you'd say this is it's really nice because it's really kind of exactly the questions you ask people. Can you lie flat when you sleep? How far can you walk before you get short of breath? Can you walk a block? And then do your feet swell in the morning? Do your feet swell during the day? And then how do these things affect what you want to do? And 42% of the people surveyed scored less than 75 on this instrument, which indicates pretty significant heart failure symptoms. Although people with end-stage kidney disease on dialysis have this extracellular volume overload, current intermittent treatments do not remove this ECV excess in many people. You might even say most. So this now is another study of volume status, but this time in prevalent dialysis patients who've been on hemodialysis for an average of 3.6 years. And if you would, they didn't do a histogram, but if you did a histogram from the data they had, it would look almost exactly like the histogram of people starting dialysis. In other words, we're not making much change overall. In this study of 8,883 patients sampled from 300 different dialysis clinics across Europe using bioimpedance, 67% were volume overloaded of at least 1.1 liters. So our prevailing treatments don't remove the ECV excess. Why? Why is that the case? Well, when we try to restore ECV, back to their appropriate levels, and I'll talk about what that means in a minute. When we try to restore them, we're thwarted by several problems. The biggest one being that the rate of ultrafiltration that we have to use exceeds the rate of vascular refill. There's the pervasive use of antihypertensive medications. And I was going to talk also a little bit about our use of concomitant diffusion just to kind of get under Raj's skin, but he's not here, so I'll skip that one. Okay, the rapid ultrafiltration rate issue. We have this checkbox for ordering, at least for inpatient dialysis, and a common check is to, or a write-in, and a common order is 10 mils to check 10 mils per kilogram per hour, to write in 10 mils per kilo per hour in the box. I just want to go through what that actually means. When we write for 10 mils per kilo per hour ultrafiltration with dialysis, if that's an average 80 kilogram person, that amounts to 3.2 liters over the 4-hour treatment, or 3-hour treatment if it's at Harborview. If you go through the calculations, if this was an 80 kilogram man and you use the usual 60%, men are 60% water, women are about 55% water, about 2/3 of that are intracellular, 1/3 is extracellular, and about 20% of the extracellular fluid is in the intravascular space. I always like to think of a normal soda-sized person as having about a gallon of intravascular plasma, intravascular water and salt. That's it. It's a small space. It's a gallon. And you've just ordered the removal of most of the fluid in this person's vascular space. It reminds me of this onion cartoon that was about the hazards of the almond for growing water, where the almond says, I don't want to drink some of your water, I'm going to drink all of it. And that's sort of how we write for ultrafiltration. We're taking off almost all of the plasma volume. So how do people survive this? I always try to tell the medical students when they're on the service that if I put you on dialysis with this prescription, you'd be dead. And the reason that patients with end-stage disease, kidney disease, can do this is because they can move volume from the extravascular space to the intravascular space and make up for it. So this is a requirement. Ultrafiltration is removing volume from the intravascular space. Diuresis does this as well. If you put someone on Lasix, it's the same thing. The volume's coming out of the intravascular space. And you have to move fluid from the extravascular space back into the intravascular space at the same speed if you want to avoid hypotension. So that brings up the whole question of and physiology of vascular refilling. How do we do this? And like in the glomerulus, capillary refilling is a combination of oncotic and hydrostatic pressures. Typically, as the fluid moves across the capillary bed, there's an initial net movement out of fluid because the pressures inside the capillary bed at the early parts of the capillary exceed that in the interstitial space, and lymph is always removing fluid out of the interstitial space to keep the pressure low. But as you move through the capillary, this switches because there's much more albumin and protein in the blood than there is in the interstitial space, and that starts to pull the fluid back, and you get a net flow inward. So this this is really an oversimplification. The process depends on so many factors. This hydrostatic pressure gradient can be altered by where the fluid happens to be. If you have, as you know, like when you have acidic fluid, for example, that's not very accessible to the to to reequilibration. So when you remove fluid out of the intravascular space, it's hard for fluid, say in the peritoneal space, to move back into the blood. Of course, you have to have albumin to pull it back. And then the integrity of the endothelium, the KF for this whole thing, in the presence of inflammation and other factors, the endothelial integrity gets disturbed, and so it's harder to move fluid back into the vascular space. This is an observational study, so it's potentially confounded by other factors, but it demonstrates the association of rates of ultrafiltration on dialysis with mortality in a large population. And with the caveats that people who need lots of ultrafiltration might be sicker than those who don't, and that the study couldn't account for all of those factors that might be different. Ultrafiltration rates, really starting at around 6, if you use 6 as a reference point, are associated with, starting with 6 and moving higher, are associated with progressively higher risks of death. And I think it's because of this and other studies that Medicare put a limit on how fast you can go at 13. But you can see that the association with risk is graded across the spectrum and really starts as early as you'd like it to start. And that really only who knows if they had made more groups under 6, if that gradation would keep going. It just shows that the rates that we use, that we consider to be normal, I think on dialysis, are super physiologic rates. They demand massive capillary refill, and many people just can't do that. It's not their fault. They just cannot refill at the speeds that we're asking them to. So when you try to take off fluid faster than refill can occur, intradialytic hypotension occurs. And this is a relatively common occurrence with lots of different definitions. The most recent one is moving to a single nadir definition as defining it, intradialytic hypotension as a drop in systolic blood pressure to less than 90 during a dialysis treatment. If you use that definition, in this study of 785,000 dialysis treatments, their intradialytic hypotension complicates about 12% of all hemodialysis treatments. And its onset really can occur at any time during dialysis, as shown in the histogram here. And not only does intradialytic hypotension itself cause problems, because you have to slow down and you can't take off as much fluid as you were hoping to, but it's directly related to post-dialysis fatigue, which dialysis patients report as the single most distressing symptom associated with receiving dialysis treatments. I think that intradialytic hypotension and post-dialysis fatigue are just the tip of the iceberg. We may not even see frank IDH. We may not, there may be people whose blood pressure goes down to some small extent, or maybe we don't even see it or develop post-dialysis fatigue. But really, that's just part of what's happening as we're taking off all this fluid and trying to make up with it with vascular refilling. A lot of bad physiology is happening underneath. There's just sort of this transient ischemia that's happening. It's leading to cardiac stunning and then potentially aberrant remodeling. It's been shown that there's a reduction in cerebral blood flow during dialysis and potentially mesenteric ischemia, which has its own set of problems. Okay, so that's one reason why it's so hard to get off the extracellular volume. Another reason is this pervasive use of antihypertensive medications. And at present, dialysis patients are prescribed an average of 2.5 antihypertensive drugs. These impair the normal cardiac response to ultrafiltration. You're supposed to be able to increase cardiac output when you have bleeding or loss of intravascular volume. But some of these drugs impair that, and they also cause vasodilation, which makes the situation worse. And so they will cause intradialytic hypotension and symptoms before the extracellular volume can be removed. Just so you're clear that I'm not the crazy person saying this, I'm actually not at all. This was something that was articulated far better by people far more important than me. And this is Belding Scribner's comment that failure by the world dialysis community to understand the dry weight method to control blood pressure has resulted in an increasing incidence of treatment-resistant hypertension, which remains the principal cause of cardiovascular morbidity and mortality. His comments were a lot more scathing if you read the article. Um, okay, so what can we do about it? So the we'll start with some historical stuff. There were case series reported from different parts of the world. Particularly, there's a TAS in France was one of the spots. Izmir, Turkey is another one where they switched patients from the typical 4 hours, 3 times a week dialysis to much longer treatments. They tapered the antihypertensive medications off. They so aggressively restricted dietary sodium intake, and they provided extra ultrafiltration treatments as needed. And the results reported from these historical studies are almost impossible to believe. In the TAS in France study using this method, 123 out of the 124 patients that were given this combination of treatments achieved normal blood pressure without any antihypertensive medications. At the time, normal blood pressure was considered to be a systolic pressure less than 140. Nowadays, we might say it's less than 130 or less than 120 even, but they were able to achieve normal tension without drugs in 99% of the people. In this other case series, it was 95% of the people. So just incredible effect sizes from this strategy. However, when you look at data like this, you have to really think about it carefully. Basically, what they're showing is something like this. This is an example of the Turkey single center series. They're saying that if you give people long, slow hemodialysis treatments, extra ultrafiltration treatments, taper the blood pressure drugs, and do intensive dietary sodium restriction, this is the data they reported, systolic blood pressure dropped by 30 points on average. But what's not shown in these historical studies is where's the control group that continued to get regular treatments. And so it's really difficult to know, are there other factors of this unit or particularly patients who choose to go to this unit? There's no comparison group. They may have selected people who were the ones who are most likely to follow through and respond to the treatments. And these are older studies, a lot fewer people with diabetes, so they may not be representative of people on dialysis today. Nonetheless, we're always taught in epidemiology that when you see huge effect sizes, it might actually transcend all the bias and misclassification and other problems in the study. And certainly these are giant effect sizes. Well, after those studies, as we know, dialysis care really shifted to short treatment times and a concomitant epidemic of blood pressure medication use. And unfortunately, the research studies shifted too. The research studies shifted within that framework to mostly studies that investigate device-guided achievement of dry weight without much modification of the length or frequency of the treatments. And the two devices that have been used in this context are bioimpedance and lung ultrasound. Just to give you a sense of what a trial of bioimpedance or a trial of lung ultrasound would be like, these trials basically take people who are receiving in-center dialysis and they'll randomize them to either usual care or some kind of device-guided volume management strategy. And the device-guided volume management strategy would entail using the device, either the bioimpedance machine or the ultrasound, to make measurements every week or two, and then to adjust the dry weight to what the device says is normal. So if you're doing a study of bioimpedance-guided volume management, you would continue to try to remove fluid until the bioimpedance machine tells you that the volume overload is 0. If you're doing a study of lung ultrasound guided volume management, you would in the intervention group, you would continue to try to take off more and more fluid until, in this case, there were no more B lines present by lung ultrasound. The results of the studies of bioimpedance are shown here. There's been sort of 4 major trials of this, and they have very variable protocols and variable results. Although in general, they were able to achieve what they wanted to achieve in terms of the intervention group getting to the point of the machine reading low or 0 fluid overload. But this amounted to a very small difference in actual weight between the treatment and control groups. You can see that it's about a half a kilo in the herd trial. The other trials used the relative fluid overload as a way of expressing the difference. Although in all the trials, blood pressure did improve in the patients that were randomized to the device-guided volume management. The lung ultrasound trials really boil us down to one called LUST, lung ultrasound to control extracellular volume. And so I'll show the results here. So here you can see it's a larger study with longer follow-up. And the first thing to see is that in patients randomized to the lung ultrasound strategy, there was a reduction in the number of B lines in the lung ultrasound group compared with usual care, where the number of B lines went up. So they were able to show that if you target B lines, you can have fewer B lines in the intervention group. But surprisingly, the weight, the pre-dialysis weight, was not much different between the groups, and nor was the blood pressure. There was a small reduction in the amount of these cardiovascular events during the trial, but that was not statistically significant. And there were fewer episodes of intradialytic hypotension in the lung ultrasound group. In an unspecified secondary analysis, they did show that people who were randomized to the lung ultrasound guided volume control had fewer episodes of decompensated heart failure compared with people in the clinical care group. Okay, so to summarize so far, we just have a couple minutes left. Chronic kidney disease, it leads to this progressive accumulation of salt and water, and that leads to substantial extracellular volume excess by the time end-stage disease is reached. This extracellular volume excess in dialysis is associated with mortality, resistant hypertension, heart failure hospitalizations, and debilitating symptoms. It is not removed by prevailing intermittent dialysis treatments in many people. And our attempts to try to remove it using thrice weekly dialysis or even an extra ultrafiltration session here and there, they're limited by intradialytic hypotension and symptoms, mostly caused by overly rapid rates of ultrafiltration and pervasive use of antihypertensive medications. Historical studies that used slow dialysis treatments and tapering of these blood pressure drugs achieved physiologically appropriate extracellular volume in 95% of the patients. Physiologically appropriate meaning that the person is normotensive at the next dialysis session they show up for without the use of antihypertensive medications. It's expected, I would expect, that controlling extracellular volume in this manner would also meaningfully improve how patients feel and function and survive, but that was not tested in any of the historical studies. So it goes back to this original idea that the current artificial kidney 1.0 is not a native kidney yet. And we could sit around and wait for technology to arrive and for better and better improvements in the machine. We've been doing that for 60 years and have got some improvements, but it's certainly going slowly. Or we can try to improve things within the structure that we have. And I think the key to trying to improve things now is to try to avoid a one-size-fits-all type of an intervention, but really try to work on identifying people, subgroups of people who really could benefit from a particular treatment and deliver the treatment to those groups to try to get them to feel better. And as I've been trying to explain, in my perspective, when you have a situation like this, the first thing you have to do is dry out the room. You just cannot work in a room like this until the water's gone. And I feel like you just can't make progress for people with end-stage disease while they remain extracellular volume overloaded. And so this has led to the concept of a randomized trial where we would carefully select people receiving hemodialysis who have ongoing volume overload despite receiving thrice weekly typical treatments. And we would define that using a combination of having persistent hypertension, symptoms of congestion, and using bioimpedance. And we would randomly assign them to either usual care or 4 or 8 weeks of a treatment strategy. And this treatment strategy would consist of a drying out routine where they get extra ultrafiltration treatments twice a week and tapering of their blood pressure drugs. And then, so we would hopefully show for the first time that doing something like that has an actual meaningful impact on how patients feel and function. In this case, their symptoms of congestion, their walking speed, and their blood pressure control. But I think the main interesting idea for a study like this is to show that once they are dried out in selected people, and I think the selected is a large group than we think, that doing that could have a lasting impact over potentially months on these outcomes, and that intermittent dialysis treatments could control the amount of volume gained from treatment to treatment, but by having underlying normal volume, there would be a long-term improvement in their clinical outcomes. I will stop talking now, take any questions. Thank you for your attention.
Hey, Bryan, I have a question. Would there, in a trial like this, have you thought about, or would there be any kind of dietary education surrounding like sodium intake?
Yeah, we would. So we would give both groups dietary information about reducing their dietary sodium to less than 2 grams a day.
Okay, great.
Hey, Bryan, it's Catherine. I am a firm believer in achieving people's dry weight, and I'm a firm believer that residual renal function matters for outcomes for these patients. And one of the things I think that doesn't get talked about is the impact on loss of residual urine output as you are working to dry the room out. And I'm wondering if you have thoughts about that, or if there have been studies. Once people's residual urine output is done, I think you're in a different box, but both I think in the PD world and in incident CKD patients, it's a big issue.
Thanks, Catherine. Yeah, that's a great question. So we have a number one safety outcome in the study is residual kidney function, with the idea that it's possible that these extra UF sessions would cause a decrease. The data on it are mixed. In the frequent hemodialysis trial, in the group that were randomized to the 6 times a week in-center dialysis, and this is over months, there was a loss of residual kidney function more rapidly in those given 6 times a week dialysis than 3 times a week dialysis over the months of getting 6 times a week dialysis. Though in the nocturnal trial, when they had 6 times a week nighttime dialysis, that loss of residual kidney function was not seen. We're hoping that in this study, because the idea is to get in and get out, to do a couple of extra ultrafiltration sessions for a short period of time and get out, there'll be less impact on residual kidney function, but it's absolutely something that we want to look at.
Thank you.
Bryan, I had a question. Since you mentioned bioimpedance as one way to monitor the volume removal, what about point of care ultrasound? You know, the studies haven't shown tremendous improvements in mortality, but there have been studies that show decreased hospitalization. And, you know, one technique is use the evidence for pulmonary volume overload as your endpoint for dialysis and volume removal.
Absolutely. So in LUST, that's what they did. They did a lung ultrasound every couple of weeks, and they used the B lines as their target, and they were able to make a difference in the B lines. In the lung ultrasound group, they dropped the number of B lines by an average of 6, whereas in the usual care they increased by 14. So it worked, and it's definitely another device guided strategy that can help reduce volume. To me, the big problem though is once you know that someone's overloaded, how are you going to get that off? If you're truly restricted in terms of you can't increase the time or the frequency of dialysis, you're going to be in that box of, well, you can try to get more off, but you're going to cause intradialytic hypotension or ischemia. I think it has to be coupled with the opportunity to get that volume off safely.
If you look at some of the guides on hypotension, they will name the 2 common changes, and that's lower the temperature and increasing the sodium, which do you think that that's going to be effective?
I don't know. I mean, the sodium bath question is being addressed in a big randomized trial now, so we should have the answer, I don't know, in maybe 2 years or a year, to get a sense of that. I'm not excited about it, but that's why we do trials, to find out that what we thought might be was wrong. So we'll know that one. I don't know of any trials of temperature. It's true though that changing the temperature can reduce the episodes of intradialytic hypotension. I get variable reports on how patients feel when they're given cold dialysis. Some people don't like it.
Okay. Thank you. Yeah, that's just the two common ones. If you look at the guides, the common teachings over the years, and looking at the references, and there may not be good enough data to really support them, but that's what I've been doing mostly when I have trouble. So
To cool it.
to definitely cool it. That's one of my first things, walk in the dialysis unit and go down to 35.5 and to help with hypertension over the years.
Steve, Bryan, there was a randomized control trial in Canada a couple of years back, the MyTemp HD trial. They randomized patients to either very low dialysate temperature in the realm of 35.5 to 36 versus a standard of care. And they achieved good separation between the two groups, but found that cooler dialysate temperatures did not reduce the incidence of intradialytic hypotension. The only difference between the two groups is that the ones that were on the very cold dialysis temperatures really hated it. They said their quality of life was terrible. They were getting chills all the time. So based on that trial, I've actually changed my practice and use kind of warmer dialysis temperatures than everyone, 36.5. So while I agree it might be situationally helpful, the evidence from the randomized trial really doesn't support use of very cold dialysis temperatures.
Thank you.
I would just say if it was me and I had end-stage kidney disease, I would just go on CRT for like 5 days and get all the water out and start dry. You got to start dry. To me, that's if you have extracellular volume overload, you're going to be in trouble.
Bryan, first of all, this was an amazing talk. It was really, really cool. Thank you. I had a question. You mentioned weight-based ultrafiltration rates, which is what we all use. Can you talk a little bit about the impact of body weight on that? It's my understanding that removing 6 mils per kilogram per hour in a 140 kilogram person is a lot worse than removing, let's say, 12 mils per kilogram per hour in a 50 kilogram person. I'm assuming it has to do with the blood volume or the intravascular volume compared to body weight. But can you elaborate on that?
No, thanks, Sherman. That's great. Yes. The dialysis experts, the DeGertis types are furious about this standardizing it to weight like this for the reasons that you said. It doesn't make sense. They said if you want to do anything, at least standardize it to lean body mass, because like you said, what you really want to standardize it to is their blood volume. And weight is not a good surrogate of intravascular volume. And if you're going to do anything to estimate intravascular volume, they say at least use lean body mass or don't even try. And they're very upset about this idea of standardizing it to just weight as we do now, because it's inaccurate. And like you said, when you get much bigger people and you put them on supposedly 8 mils per hour, that's a very high rate, and that's more likely to cause problems.
Yeah, just to add to that, Bryan, I mean, there's been some recent thinking even that using a straight volume amount, so 800 mLs to a liter, irrespective of someone's body size, might actually be a more consistent prediction of mortality than benchmarking it to body weight or even body surface area. So, a lot of thinking, and that's, you probably saw my chat comment. That is one of the reasons why CMS removed this as a quality marker in its quality incentive program. So it's no longer there.
So you can go as fast as you want.
You could always go as fast as you want. You just had to report what rate you were going at, but now you no longer have to do that.
It would be interesting, I think, to see what rate a normal person could tolerate. If you put a non-dialysis person on, I would think it's like 100 an hour would be pretty bad. What we need obviously are devices to measure intravascular volume, and there are some on the way.
All right. Well, thank you so much, Bryan, for a wonderful and very interesting talk, and all of our speakers today. Um, if no further questions, we are over time now. We can adjourn. I just want to give a quick reminder. So for next week, we have a sort of special grand round session. It's going to be a joint grand rounds with our cardiology colleagues, and a special thanks to our very own Dr. Karen Dawalski, who's going to be presenting, as well as Dr. Kara Tasakis from cardiology, and Nisha Banzel is going to help host them. This is going to be, because of scheduling for cardiology, and I believe around like their timing for the cath lab, it's going to start a bit earlier. It's going to start at 7 a.m. as opposed to our typical 8 a.m. Time, and we'll send a reminder out for that. And it will be in person, as well as I think there will be a Zoom option as well. All right. Well, thank you so much, everyone. Otherwise, have a wonderful weekend. We'll see you guys next week.